Hello, and welcome everyone to the very special edition of the Lipid Insights podcast. I'm coming to you live from the MNLA Fall 2025 Clinical Lipid Update in beautiful Scottsdale, Arizona. I'm your host, Dr. Peter Jones. And I couldn't be more excited about being here surrounded by some of the brightest and most passionate professionals in our field. If you're tuning in from across the country, this podcast is your backstage pass to the ideas, conversations, and energy that make the CLU experience unforgettable. We've got a fantastic discussion ahead, so let's dive into this spirit of the NLA Fall CLU. Today, I'm very fortunate to be here with Dr. Nivedita Patni. She is an associate professor of pediatrics at UT Southwestern Medical Center in the Division of Pediatric Endocrinology in Dallas, Texas. She serves as the program director for the Pediatric Endocrinology Fellowship at UT Southwestern and established the Pediatric Lipid Clinic at Children's Health. She also tends to deal a lot with rare genetic pediatric dyslipidemias. So, your CV is pretty long, and I welcome you here. Let me just turn it over to you. What really do you do every day? What's your passion about the topics we're going to be discussing today?
First, thank you so much. I'm so honored to be here today. My passion has been pediatric lipid disorders since early residency. I think early part when still young and green, I came across a patient with lipodystrophy. And so when I came for my fellowship to UT Southwestern Dallas, I had always known Dallas, UT Southwestern is the place with all the experts in the lipids and the lipodystrophy field. So I shadowed them, saw every and any patient that had any lipid disorder. And I was blessed to be able to start my lipid clinic pretty soon after my fellowship.
Oh, that's fantastic. Well, you're giving a presentation today on pediatric dyslipidemias, particularly focusing on some of the rare disorders. And that's wonderful. I mean, I think that's an area here at the NLA that we're trying to get this concept of being able to identify things earlier, so that earlier is better if you can identify lipid problems and take care of them as far as a person's overall health and cardiometabolic health is. But what I really would like to ask you before I get into some of your specifics that you do in the lipid clinic, I want to get your opinion on well, first of all, what is the incidence of pediatric lipid disorders?
So I honestly don't want to quote an incident at this point because it has changed a lot since the universal screening and selective screening have come up.
Okay.
So there is known guidelines about universal screening on every pediatric patient around 9 to 10, and then again about 15 to 17.
Okay.
So the screening guidelines have been out there since 2011. AAP had published it. But I don't think people were following those as much as they should have, because what's the point of screening if you don't have a referral point?
Correct.
So I think in places where there is a pediatric lipidologist or a cardiologist, endocrinologist interested, people are screening more and picking up more, versus there might be other places it's not happening because if you can't treat it or refer, then they are not doing it.
Well, yeah, I think that's it. We've also got sessions here on pediatric obesity and the incidence of that. I mean, we're talking about, intervening, identifying, and possibly intervening earlier in life. And so, what do you do with pediatric lipid problems? I mean, yes, you should screen, and what do you do if they happen to be their BMI's higher? What's that going to lead to?
Exactly.
So, there needs to be not only a way to identify it, but there also needs to be the ability of primary care doctors to want to be able to help and send those patients where they need to go. So in the lipid screening in pediatrics, it's universal starting at age 10?
Yes, 9 to 10 is
9 to
the
10 years old?
cutoff, yes.
And is that in the EHR? Is that automatically in there? Does it tell them to do that?
No, it doesn't. So it is something that pediatricians have to be aware of. It is not, nobody's triggering a alert at that age.
Okay.
So nurse practitioners, PAs, family practice, pediatrician, everybody would have to be aware of this.
Is LP little a now part of that universal screening at this
Not
age?
yet. That is pretty controversial. So universal screening is just a random lipid panel, and then they request to repeat it if it's abnormal.
Okay.
LP little a or ApoBs are not part of that. I think they're only very specifically being used by lipidologists.
So they'll do the lipid panel non-fasting, and if everything turns out whatever normal, it's fine.
Yes.
If triglycerides are high, or if something's high, you got to come back fasting or whatever.
To come
for the
back
kid
fasting
and get it
yes.
redone. Is that
Otherwise, you just repeat it again in 15 to 17 years.
Okay. Well, I think that's good. I mean, hopefully, pediatricians and those who take care of children and adolescents are aware of that.
Yes.
And we'll check the EHR and make sure that it's at least done once, starting at age 9 or 10, and then maybe when they get to past puberty into adolescence, look at it again. Is that correct?
Yes.
Okay, that's fantastic. Well, okay, so I guess as the pediatric lipid specialist, if these patients get screened or figured out, doctors then send them to you. So do you see FH patients?
So not anymore. For a few years, I was seeing all high LDLs, all high triglycerides. So a lot of FH, a lot of FCS, a lot of familial combined lipodystrophies. But recently, in the last few months, we've had a cardiologist who's showing interest. So she's taking over the LDL and FH, and I'm doing primarily high triglycerides at this point.
Oh, okay. So
I continue to follow my FH, but all the new referrals are going to
that specialist cardiologist.
Yes.
Okay, so focusing on high triglycerides, I mean, there's a spectrum of hypertriglyceridemia. You know, some of it could be related to their background childhood obesity, for instance, if they happen to be obese, as a cardiometabolic disorder. But the more severe, this is the ones where you want to catch it before it could have a fatal event like fatal pancreatitis, which unfortunately I saw one as an 18-year-old very early in my career with triglycerides of 12,000. But that was what we now call familial chylomicronemia syndrome, as opposed to multifactorial, maybe chylomicronemia syndrome. So FCS, you see those patients?
Yes, I actually have about 11 or 12 now patients with FCS in my practice. But considering I have over 200 kids with high triglyceride, and by high, I mean they are over 400 milligrams per deciliter at point of referral, majority are still either secondary to diabetes, obesity, metabolic syndrome, or the MCS. So FCS is still a smaller group. Okay. There are other rare lipid disorders like lipodystrophies too, but most of the monogenic causes are still not as prevalent.
Do you do the genetic testing when the triglycerides are over 1,000? Do you look for FCS with a genetic test?
Yes.
Specifically? Okay.
Yes.
So that's what you do. And if it doesn't come back homozygote for LPL deficiency, then it must be MCS or something like that, right?
Yes. But mostly clinical picture can help guide in pediatrics. So being able to do genetic testing is a very recent development even for me. There was a point when the insurance companies were not covering it. And so it was a struggle. A lot of them just had clinical FCS. I feel in the last year or so, it has become a little more easy to get genetic testing done. There are also some sponsored programs. I think that's why it is getting covered. And for that reason, so a group of us, physicians, endocrinologists, cardiologists from Canada and US, we came up with the North American FCS scoring system. So there is an app and website where you can put in all of the criteria to help figure out clinically if it is FCS or not, if you are not able to get genetics.
So how do you look that up?
So it is on the MNLA website. It's on the foundation, the Learn Your Lipids Foundation one. And it is also, if we just look up North American FCS score on Google, it will show up.
Okay.
So there are two separate ways of accessing it.
That's fantastic. So do FCS patients end up with you simply because somebody's astonished that their triglycerides are 2,500, or do they end up because they got an episode of pancreatitis and, oh my God, this is terrible, I've got to send them to a specialist? What is
So
it?
It's both ways. I have a lot of babies that have been diagnosed, and those babies were usually just, they came to ER for some other reason. They were there for abdominal discomfort, GI bleeds, anemia. And then when the blood was drawn, they could see that the serum was mostly white. Labs showed triglycerides of 3,000 or 4,000, and then they send them to me.
Okay.
So I have at least 4 babies at this point. All of them were diagnosed before any pancreatitis episodes were happened. But there are some kids who are presenting later with pancreatitis. They just kept having abdominal pain, and everybody just kept ignoring them. It's okay, avoid eating for a day. It got better.
Right.
And then so they were living with it for 5-6 years till somebody actually took them to ER, got the blood, and then realized it.
I think we're now fortunate that we have a treatment for FCS, right? Why don't you
Still
tell us
not
about
for
that?
kids.
Huh?
It's still not approved for kids.
It's not for any even adolescents?
Not yet. It's 18 plus at this point. I know that the
What's the
clinical
drug?
trials, olezarsen.
Olezarsen.
Yes. So we have an ApoC3 inhibitor that is approved for 18 plus. Orlistat is actually a medicine that's been out there forever for obesity. And I have quite a few kids on Orlistat. It helps significantly reduce their triglycerides.
Wow.
So these kids have to be on minimal fat diet all their lives. They can never have a cheat day. They can never have days when they can eat a lot because their body just cannot make any chylomicron. So any fat they're eating is going straight as a big load of chylomicron load, and they can get pancreatitis every single day. So since diagnosis, whichever, is it a baby age or a later, doing fat counting in the meals is an essential component. So just like diabetics do carb counting in grams, I teach them all how to count their fat. And the severe null mutation LPLs can sometimes just stay on 10 to 12 grams of fat per day.
Wow.
I've had a few kids who can go a little more, but it is severe fat restriction forever. So the life can be very restricting. We did a pilot study a few years ago in 2 kids with GPIH PP1 deletion, and we realized that adding Orlistat in the diet with these kids helped reduce, even with the 10 to 12 grams of fat, the triglycerides sometimes can stay about 2,000.
Oh, wow.
1,500. So this one brought it down by 50%. So some of these kids were staying in the 700 to 800 range. And any value less than 1,000 is very reassuring to family, parents, me, everybody, you know, that they are staying in a zone when they are not quite stressed as much. So a lot of these kids are benefiting from Orlistat in addition to the lower fat diet. Now, the benefit is that Orlistat is just not tolerated in all of the historical studies because of the side effects.
Right.
And the side effects happen only if you're actually having fatty food.
Oh.
So these kids are adding that in addition to the lower fat diet. So they tolerate it very well.
Okay.
There is no side effect. They are growing well in height and weight. I keep an eye on the vitamins. So I'm always checking ADEX and they are on replacements. So we actually have a double-blind placebo-controlled trial open to make it a valid, and people don't have to pay the cash pay price. So hopefully it can be approved for this indication. But right now we are using it because it works.
Yeah. Well, that's awesome. Do these kids also have to be on MCT oils?
So MCT oil is a great caloric replacement because, again, their diet is so restricted that sometimes we can have problems with giving enough calories. So MCT oil bypasses the entire chylomicron pathway. And so giving that helps with that calories. It also is a good base to be able to give food that needs oil.
Yeah.
So when they are fixing anything, in the neonatal phase, it's the easiest to manage because there are lower fat formulas. There are these 2 or 3 companies, Monogen, Lipistar, they are so low in fat, and whatever is the component is mostly MCT oil. So the neonatal phase, I feel, is the easiest for me to tell. You know, we just switch off the breast milk or regular formula, switch it to that. When the weaning phase comes, I educate them it's okay to add the pureed fruits, vegetables, but when we are trying to prepare food, then add a little MCT oil. It gives some flavor, and also families can give whatever they are eating, but prepare it separately with MCT. It has a very low smoke point, so you cannot fry in it. You cannot cook a lot in it, but it still helps prepare a lot of specific dishes that family is eating and they want to give the kids to. So MCT, few tablespoons spread throughout the day, helps gain weight and gives the flavor, and
As
they can
grow,
actually get.
That's awesome.
Yes.
So with ApoC3 inhibition, olezarsen, when do you see that becoming available for at least adolescents under 18, maybe 9 to 18 or any age?
So I think they're
when?
starting a clinical trial in 12 to 18 group, and then the goal is to make it for 2 to 11 as
11.
well.
Okay.
So I'm hoping soon.
Okay.
Now, even with olezarsen, though, ApoC3 inhibitors, even now, because they're so new, still technically an orphan drug, is not telling people to be able to have more fat.
Right.
So it is in addition to low-fat diet.
Yeah, they got to do all the same things they do in addition to
Exactly.
this. Yes.
But I feel the main struggle is having such a restricted diet throughout the life. Because I see the kids going to school, going to birthday parties, going everywhere, and they would have one day when they ate few nuggets or a burger, and then they are in pancreatitis right away. So the question that everybody asks me is, when can they actually eat like other kids? Which I think we're still not there. The gene therapy got approved in 2012 and was gone in by 2016. It was a few $1 million.
Wow.
And a lot of intramuscular injections. So I think the question and the goal eventually is let them be kids.
Well, the other thing too is that you see them and you get them on treatment and you spend all this time telling the parents and the young kids how to prevent pancreatitis and what to eat and all that. And then they get to be, quote, adults.
Mm-hmm.
My question to you is, how do you pass them off to adult medicine?
Yes.
Care? I mean, how is that?
So I'm actually very fortunate to be at UT Southwestern. We have such good adult lipidologists. So I think my job is easy. We have Dr. Garg and Zaid Ahmed on the adult side. So I transition them, but I have a lot of these kids who are going to college elsewhere.
Yeah, they go out of state, right?
And they are more than happy to be away from mom, who cooked every food they ate for 18 years. So then they get into things. So I've actually had both extremes. I've had kids who have gone to college and then they wouldn't eat for a couple of days just because it was stress for college, exam, moving. And so they can get a triglyceride and after a couple of days of not eating, and it looks beautiful because they really cannot make chylomicron if you're not eating.
Right.
Versus then there are days when they would go and eat pizzas and then they're having pancreatitis. Most of the families do very well because they are born with it and they understand how important it is. So they do well, but they always have these bad days when people would want to do things.
That's probably what the NLA is really helpful for. They've probably got a list of specialists around the country. So if a kid goes off to college and you're trying to pass them off to an adult medicine follow-up, at least you can refer them to somebody and hopefully they'll continue getting that kind of follow-up. And if they go to jobs and other things like this around the country, there are people who they can connect with, hopefully, to keep them, because this is for their life, right?
Yes.
Speaking about that with FCS, is it possible to do gene replacement for LPL?
So that's what I was saying. Glybera was the first gene replacement that ever got approved. So in Europe, in 2012, they did work on it, but it was, I think, 30 intramuscular injections under anesthesia that had to be given. And it was 1.6 million, if I'm correct, price for the therapy. And so they had one single person who got it between 2012 to 2016. And in 2016, then it was shut down.
Any other possibilities that will come up again?
I'm hoping with the whole new era of CRISPR and people trying to help with genetic diseases, maybe a decade more, but I think it will at least take a decade.
It'll take a while for that to happen because it is a lifelong disease. You really wish you could come up with a way to solve that. When you identify it at 6 years old, you'd like to say for the next 60 years, I can take this problem away. It would really
and
be
I feel I see enough Mendelian disorders to hope that these things have a fix, because I see a lot of lipodystrophies too. They all have high triglyceride as well. So I see the acquired, congenital, partial, generalized, all of it. I have a lot of kids with lipodystrophy, and again, the long-term goal is hopefully we have a fix. That
was my next question about your interest in lipodystrophy. Tell a little bit more to the audience about how you identify it and what it is. I mean, besides the lipid disorders, what else is going on?
So lipodystrophies are a disorder in which your body cannot deposit subcutaneous fat appropriately, but it keeps depositing a lot of visceral fat. So the generalized subtypes are easier to pick because you really look very muscular, even acromegaloid. But you have severe metabolic conditions. So they have diabetes, acanthosis, and high triglycerides, almost sometimes high as FCS. I have these congenital generalized lipodystrophy kids with 10,000, 12,000 triglycerides too.
Oh, wow.
So their insulin resistance is that much that the triglycerides can go that high, and severe hepatic steatosis. Partial ones are trickier to pick because the familial partial lipodystrophy, which is usually caused by lamin, doesn't present till about adolescent age. So the phenotype is normal kids. And then slowly around 9 or 10, they start losing some of the extremity fats, but they deposit more on the trunk. They can have some humps. So it sort of starts giving a little Cushingoid appearance. But again, the metabolic features can get pretty worse pretty quickly.
Is it easy to distinguish that as a routine pediatrician to say, wait a minute, you look like you might have this genetic FCS and you look like you have lipodystrophy? Is it easy to do that, or the triglycerides so high that it could be one or the other, and you're the one that makes the decision?
So I feel that if they have attended any of my talks, lectures, webinars, then it is. But these things are rare enough that if you have not seen one of the meetings or presentations, then people won't pick it.
Yeah.
Lipodystrophy was not even part of the bigger endocrine books, I think, till recently. I have written a few chapters, so I think it's becoming a little more aware. I think I do a lot of presentations in national meetings as well. So I feel that people know me. So if they have a suspicion, like they kind of have some idea, okay, I think I heard about this, they email me.
Oh, okay.
I get a lot of emails and phone calls that I saw a kid that kind of looks like the photos you have shown. Can you see the kid? So I have kids coming from all over, from Kansas, from California, Arkansas, Oklahoma, because I just get one phone call and I'm happy to see them and just to be able to make diagnosis.
Do we know the genetic defect?
So for congenital ones, yes. We know 4 genes. So there are 4 subtypes right now. We know the ACPAT, BACL2, PTRF, and the 4 ones. But there's, of course, still a whole knowledge gap. There is a lot of unexplained ones. The more we do whole exome, whole genomes, we might still find more causes. Partial subtypes have gone up a lot. I think it's about 10 now. But the lamin one is over 90%.
90%.
PPAR gamma is becoming a little more prevalent. The tricky with PPAR gamma variants is that they sometimes don't have subcutaneous fat loss for decades. The metabolic features can start in teenage adolescent years. So I've picked up a few PPAR gammas just because the level of metabolic issues with them was so extreme.
Okay.
But they have no phenotype externally.
Okay.
That they kept having recurrent pancreatitis. And so that's also the tricky thing. With some of these kids, it's difficult to assert certain that the diabetes came first, the triglyceride came first. And if it is triglyceride first, diabetes later, we should always look into these things.
Okay.
Because it is probably because of the recurrent pancreatitis that their pancreas have died out and they got diabetes.
Okay.
But a lot of people don't ask these questions. A lot of people don't examine as well. So
yeah.
Teenagers and adolescents are known to be wearing hoodies.
Yeah.
Even now the jackets have those things too, in which just thumbs are out. They cover everything. So I have seen xanthomas here and here that the parents didn't know of.
Wow.
Because they have these jackets literally till here.
Couldn't see them, yeah.
And they are very hesitant when they come in the clinic and you ask them, can I just take this jacket off? And they will look at me like, do you really need to? Because it's the age thing. They just don't like somebody examining them. But they can get severe xanthomas and extremities. It could be just on the strap. So any place that's having abrasions, they could have it too. So examination is very, very important. I'm still old school, and Dr. Abhimanyu taught me this. I think I've learned from the best. So I carry skin calipers in my clinic. I have my dot phrase in Epic, in which, I do it, I keep entering it. So my examination has skin folds because I want to see what extremities is, what trunk is, to diagnose partial lipodystrophies.
Wow. Is there any treatment for lipodystrophy?
So there is metroleptin replacement for generalized. Partial metroleptin is not approved in US. It is approved in EU and Canada and Japan, actually. But US FDA was not as convinced with the improvement. Now, that being said, metroleptin replacement helps with metabolic features if you really don't have intrinsic leptin. Partial, some of them have intrinsic leptin. So the benefit is variable. It can also cause some neutralizing antibody effect.
Okay.
So I can see the FDA's point of view as well, because if you have your intrinsic leptin and you give external metroleptin and you develop neutralizing antibodies, it's going to stop everything.
Yeah, it'll stop everything, yeah.
Let's not make things worse that are not needed. So in US, for all generalized, we can use it. It helps a lot. A lot of kids can get significant reduction in insulin dosing, much improved triglycerides. So it is great. It works when it works.
Okay, that's awesome. You see any other rare disorders? You see cytostolemia or CTX or anything?
Not yet. I have written chapters without seeing kids.
Yeah,
These are some of the diagnoses that are getting picked up more later in life.
yeah,
Because people are not checking. The diagnosis that I think is getting picked up more now is lysosomal acid lipase because it's easier to check. I
Yeah.
don't have any personally that I'm following. I think Dr. Wilson probably has some in our area. But cytostolemia and CTX are getting missed in pediatric population completely.
they might get picked up later. Hopefully, somebody thinks about it, or
Yes.
the person gets referred to an adult lipid specialist
Yeah.
who might.
But CTX has such minimal GI symptoms as kids. And I'm telling you, in kids, GI symptoms are always bypassed because, it's okay. You're fine. The parents just like, it's okay. So that's why a lot of kids with recurrent pancreatitis too, they would just have this pain and the parents would ask them to sleep on it. And I'm a parent. I can't blame them. I have kids who come in the morning the day they don't want to go to school and just say, can I miss the school because I have bellyache. So
Right.
it's difficult sometimes.
Yeah.
But in serous pancreatitis, I feel in a lot of my lipodystrophies, FCS gets missed.
Awesome. Any other rare lipid disorders you'd like to bring up?
Not lipid, but I think I have picked up a few progeria diagnoses as well. Not much that we can do, but I send them on the genetics way. But yeah, some of the lamins. But I think it's just more because I do so much phenotype-genotype correlations that I had that eye. If I've had kids refer to me for short stature for growth hormone therapy, and I was like, no, you have progeria.
Right.
So things like those, I think endocrinology everywhere have rare diseases
That kind of
we
thing.
pick up. Yeah.
That's awesome. Well, listen, I mean, I know your presentation is going to offer a lot of insight to our adult lipid experts here at the NLA. Hopefully, they'll be able to talk to their local pediatricians who might be interested in these kind of things to see if they can work with somebody to help establish some sort of a connection. But I think this is just wonderful that you're here to educate all of us on these, just the idea of these rare genetic problems that are here. They can sometimes be fatal, and they need to be identified, managed, and treated by somebody that knows what's going on. And hopefully we'll get better with screening.
Yes.
And that will also help with the pass off to adult medicine, that they'll know which patients are coming to them who need the earlier, longer, lower approach to keeping LDL under control, for instance, and certainly triglycerides.
Yeah.
And not miss it somewhere into younger adulthood. So I think that's fantastic. Well, listen, this has been a great conversation.
Thank you
I
so
really
much for having me
appreciate you
here.
being here. Thank you so much for coming to the fall clinical lipid update here in wonderful Scottsdale, Arizona. And I hope I get to see you again at another meeting.
Yes.
Thank
Thank you
you.
so much. It was my pleasure. Thank you.